All right, thank you. Well, my name is Dr. Raki Gisheru. I am an anesthesiologist by training, and I am currently at Kenya Medical Training College, where I train middle-level healthcare providers in anesthesia and other areas. I'm also the e-learning coordinator, and I've also been doing a bit of simulation because we've just recently at KMTC launched our, not launched, but had a simulation lab installed. So that is me.
Nice, Dr. Ari, thank you very much. So today, I guess we're going to talk more about how to use the simulation in building hospital teams, and what's the vision and the plan, and how other people can engage. So we can't wait for the projection. I think it's an important learning, and we can't wait to hear more. Over to you.
Can you give me a minute? I share my screen.
Simulation. Perfect.
Sorry, I'm still trying to get my slides to move. Go to the start.
But we can see your slides now.
You can see my slides. Okay, fantastic.
Yeah.
All right, so I will say a little bit about our simulation lab as I go along. So today's talk, as we have had, is about using simulation to build hospital teams. And there are many things you could use simulation for. I think a lot of us have used simulation for purposes of training, and we've participated in some simulations to some degree in training, even though it's not a very widespread practice. As I've interviewed people, I've found out that there are still some people who did not experience the use of simulation in their training. But the aspect that I'll focus on today is how to use simulation to build your hospital teams. The picture that you can see here is our simulation lab. It has two sides to it. On the back there is the critical care area, and this side over here is the operating theater area. And I'll show you other slides that you will see how it looks like, and maybe some of the equipment that we have. But if we were to, talk about what simulation is basically where you simulate or set up what you would call a real life experience, and where you can then you have healthcare providers practice and learn their medical skills in a safe environment. And the safe environment is key, because many times when we do our evaluations, even in our NMNMs, because of the fact that they're centered around incidences that have happened, usually we're not able to discuss some of the pertinent issues that might have come up because the environment is not necessarily seen to be safe. But we say that what happens in the sim lab stays in the sim lab. So when people come to the simulation lab or into a simulation scenario, they are made to understand that it's a safe environment for them to practice and showcase what they know as individuals and as teams. And then that will be used to guide conversation, and not actually for appraisals or to assess a grade team performance. I've said that there's also what you call simulation-based medical education, where you have then medical activities that use simulative aids that replicate clinical scenarios. And I think a lot of health institutions now have especially skills labs where people can learn specific skills, and most of the skills labs will tend to have what you call task trainers. So they'll have maybe a bathing simulator, or they'll have an IV simulator, maybe even chest sound, breath sounds, mamas, and things like those. People can practice how to put a BP machine and take a blood pressure, temperature, insert NG tubes. So different tasks that are available in skills labs that people can use, and has been in practice for a long time. So the question is, why should we simulate? What are the advantages that one can draw from simulation? One, I think I've already said that it's a safe environment. And what you want to achieve when you have simulation, or when you simulate, is to have the participants stop and reflect. So the aspect of debriefing is emphasized in simulation. Even debriefing would take longer than the actual simulation. So maybe a simulation would run for 10 to 15 minutes, and then you spend a half an hour to 45 minutes debriefing, asking the participants to reflect on how it went, what went well and what didn't go well, and why, and some of the things that they would take on to put into their own practice. So they internalize the process. Debriefing should take place immediately after, so it helps, because then sometimes people don't remember the scenario well when other things have happened. So that's one of the things that you can draw from a simulation that is I have found to be very useful. The other aspect is the supporting of improvement of healthcare systems and processes. So you can use simulation to analyze maybe a protocol that you have put in, and you have people run through that protocol, and you see how it works, how well they've understood it, what areas that still need improvement. So it can be useful in that sense. If some people have used simulation for research purposes, so they have done certain things in their researches or in their institutions, and then they have used that to assess either knowledge gain, skills gain, teamwork, and you grade and you see the progression. Then there's also the fact that people can use simulation for events that don't take place often. And I think we did a lot of that last year when we were learning to dawn and dove. And, so those were opportunities where, people had not done that and were learning how to do. And we can also, as institutions, pick out things events that occur that can be quite difficult to manage or create crises that don't occur very commonly or often. So that you can use them for those, conditions that, if they do happen, are critical, but they don't happen all the time, and you want people to keep their skills sharp. Then there's the aspect of compartmentalization and fragmentation, which is, I think, one of the reasons why we felt simulation is something that we should think about when we're building hospital teams, because cadres train separately, and therefore, and they train separately, and then they are required to come and work together. So simulation is one of those things that can help, techniques that can help people to connect with one another, and so prevent people from just thinking in a tunnel way, in just their compartment. They're able to see other people's point of view and see how people see other things, as in scenario, and then as a team, you're able to have what we call a shared mental model. Now, where would you do simulations if you wanted to do them for your hospital? One, it is what we call off-site simulation at a simulation center. And so, KMTC is right next to KNH, so we have a simulation center, and KNH is very welcome to come and see and also utilize. So you could do that. You could take your staff to a different place, a simulation center. I think even the university has been using, I think, Chiromo, where they have a simulation center and the students go. That's one way you could do it. The other way, way you could do it is you could have simulation that's off-site, but within the hospital. So it could be you take a spare room in the emergency department to run a simulation for maybe maternity on how to triage, or you could use the PACU to perhaps do some critical care skills training or simulation. So you're using your off-site, but within the hospital. Simulations can also be within the hospital, but now in situ, what we call in situ, where you are within your department. So if you're in ICU and you have got a spare bed, that's empty, you could run a simulation on your bed. So it's an in situ simulation. Now, simulations can be either announced or unannounced. So the unannounced are what we call drills. And the announced are the ones where you schedule. You say, let's do this on Friday in the morning, we have a simulation. Now, each of those has got advantages and disadvantages. One, of course, is that if you're doing off-site, you have to pay for the utilization of the offsite, or you have to have built it. If it's yours, you have to transport the persons there. But that's a disadvantage. An advantage would be that then you have dedicated equipment that is available for simulation. That when you move your staff, they are committed to what they're doing because they've been given the day off to do that. You have the advantage of perhaps audio-visual, where you can record and review the videos, and then you have like syntax that you can use. If you decide to use in situ in your hospital simulation training, it has its advantages. One, you could it's easy to set up because you're using what you have. You're using your beds, your trolleys, your drugs, your equipment. So it's a low cost. But and then you have your teams right there. So it would enhance team training quite easily. But the disadvantage that you have is that if something comes up, then you might not be able to run the simulation. So if you had planned for Friday morning, and then you come in the morning and find the bed you are going to use has been used in the night with this patient who was very sick, or you've had a mass accident and therefore now nobody's free. So there are those disadvantages. But the thing that I have found useful is that if you use an in situ, is that it really enhances team training. So I would encourage that hospitals think about doing simulations within their departments and within their hospitals, as opposed to trying to move, because then you generally would plan for your department or for a specific team, and therefore that team is experiencing the simulation together. We all know that healthcare is no longer a one-man guitar. It's more like an orchestra where you have got a conductor who probably be a team leader, and you've got all these players who are trying to play together to produce a beautiful sound, where in healthcare that would be patient safety and efficiency in the system, in quality healthcare. So that's the thing that we always need to remember. And therefore, whenever we think of simulation, you have to think of how it plays into your whole system. So if my middle picture here is two gentlemen who are having a great time on a motorbike, and as we all know, this looks like a disaster waiting to happen. Just by the posture, they don't have safety equipment, and one of them is just enjoying himself balancing on that motorbike. Of course, if the unfortunate happens, this person, or two of them, might end up in your hospital, and usually the first place that they would land would be in the A&E department. And within the A&E, you have several professions. You have nurses, you have the clinical officers, you have the medical officers, you've got the registrars in there. And then they will also interact with the medical records person, because of course they need to have documentation. And then maybe if they have some fractures or injuries, then you might interact with the persons in imaging. And then you'll need some blood works, and perhaps you need to take them to theater, and perhaps they need to be admitted to ICU after that. And then they'll need drugs. So all of these are different components of the healthcare system that have different teams who participate. But the thinking is that all of these teams will converge in providing care for this patient, and that the outcome will be that it'll be an efficient and a smooth experience. And really what we're saying is that professions need to work together to provide that efficient healthcare, but to do that, you need to be cognizant of the fact that they need to learn how to do that together. So this is what we call interprofessional teamwork, where you have, you know that there needs to be cooperation, coordination, and collaboration into providing patient-centered healthcare. So that if you're looking at teams, what would be the characteristic of or the principles of good interdisciplinary teams? A good team is one that has got some of these characteristics that are listed here as themes. One, that there is always, when they are functioning together, there is leadership. And of course, leadership means followership as well. So every time as we are connecting together to function in our healthcare settings, there is leadership and followership. And then there is communication, that people are effectively communicating with one another. They are understanding one another, and messages are going across from between team members clearly. Then there is the aspect of that we are continuously developing as a team. We're growing, we're training, we're learning, we're developing each other, or yes, also as individuals. There's also the fact that there are resources that we're using and resources that we're utilizing, which could be people, it could also be systems, it could be equipment. So there are many things that come together as resources. We are also, a good team is also cognizant of the skill sets that are there. So we're developing skill sets, but we're also cognizant of the skill sets that people have, and the skill mix that we're bringing to the table. We are developing a culture, and this culture is a culture of trust, valuing contributions, nurturing consensus, bringing everybody on board. It's something that looks like it can be automatic, but it's really something that needs to be inculcated. And then there's the knowledge of each other. So we are working as a team, but we recognize that we are also individuals. So we support one another. We share and understand each other's strengths and weaknesses, and we support where we need to. And then there's a shared mentor model, which is a clarity of vision, that good teams need to be seeing the same thing, moving in the same direction, and not against each other. Many times when we work in teams, we realize that, or we notice that some of the weaknesses that we have that are brought out, especially in meetings, is that people don't have the same vision. So one group could be saying, but this is what we want to achieve, and the other says, no, but this is the main thing that we want to achieve. So to have good interdisciplinary teamwork, there must be a shared mental model, clarity of vision. Then, of course, good teamwork, interdisciplinary teamwork, requires that there is quality and assessment of outcomes of care. So we are always giving feedback. We're reviewing. Teams are looking at outcomes, and I think we do this to some level with our M&Ms, and it's important to say that we need to keep doing that all the time. And then, of course, there is the mutual respect and for one another. So those are the 10 principles of interdisciplinary teamwork. So how can you get there? How can you develop teams so that then they look like that? One of the ways that you can do that is through training. And the training that you could do are several. One, you could use what we call principle-based training. The ones that I have put here are CRM-based training, which is crisis resource management-based training, or you could use others that have been that are available, like the team steps, which is I think the US Ministry of Defense, and it's open resource, and one can look at it, and it has even an instructor training so that you can learn how to use it and then use it to build your teams. And they have various guides and resources that you could use. There's also med teams as well. Or you could use method-based training, which is the simulation-based team training. And what you're using now is simulation to bring out, to train your teams. What we have done is that we have used a combination of simulation-based team training and CRM. So in our simulation-based training, we use simulation with scenarios of things that we see as people see more commonly, but I think our focus has been more on critical care. And then also incorporate CRM principles, which is a crisis resource training. But you can see that you can also use tools to build your teams, and there are various tools that you can use, and tools that even you have developed. I think the SBI is one that's most common that can be used for handing over, but there are many tools that we always use that we can utilize to build our teams. Let me say a little bit about CRM. Crisis resource management was drawn from crew resource management that is used in the aviation industry. And I think everybody knows that high stakes industries, especially aviation and medicine, are always prone to crises. I think every day when we go to work, that's one of the things that we are cognizant of. You're waiting to see what's going to happen because crises happen all the time. And so in the aviation industry, they then came up with a way in which to have their crew think in a certain way and perform and behave in a certain way when they have a crisis. And therefore, the crew resource management. And it has 4 components. 1, leadership, and leadership comes with followership, communication, situational awareness, and resource utilization, which also incorporates decision making. So you're using all resources available to make decisions, and resources is people as well as equipment. This CRM was adopted early by the anesthesia fraternity. And if you read Gaba has written a lot about CRM in anesthesia. And in anesthesia, it's called ACRM, which is Anesthesia Crisis Resource Management, where a lot of emphasis is placed not only on technical, but on non-technical skills, because it is important especially in crises. So what is CRM? CRM basically is a management system that is using all resources, especially non-technical skills, and in communication, situational awareness, leadership, and decision making, to ensure that you have safety and efficiency in patient outcome in healthcare systems. So that's basically what you're looking at, and it has different components.
Hello, Daktari, Dr. Wagaki. Sorry, Dr. Wagaki, we can't hear you. Yeah, she's dropped off. I think she'll join in a few.
Okay, so sorry about that. So I was just still talking about CRM, and the other aspect that I have found that is useful in this simulation-based training is about leadership and followership. And I kept repeating that because many times in the crisis, people do not say who is the leader. They expect that somebody is the leader, and especially if you have a team where you have doctors, nurses, when a crisis resolves, people automatically think that the doctor is the leader and the rest of us are, everybody else is a follower, and perhaps maybe the doctor is maybe might not be the best person as a leader, or the doctor has got another role that they need to play, and not necessarily be the leader. So take, for example, if you have like a cardiac arrest on the table and you have maybe in theater, the assumption is that perhaps the anesthesia provider is the leader, and perhaps and many times anesthesia provider is probably struggling with the airway. So because they're struggling with the airway or trying to do something about the airway, they might not have a global view of what's going on. So we emphasize when we're doing the simulation-based training is that the leader is somebody who steps aside and has a global view of the situation, is then giving direction on what should be happening, and is able to anticipate and plan and allocate attention and reevaluate what is going on, so that then the team is able to function. And leadership can shift from person to person. So if the leader then needs to take on a specific role, because it's needed, then they stop being the leader, somebody else is the leader, and then they continue with their role. It has worked well when we practice it. People are able to see actually their mental, how they have thought about who is a leader in a crisis. So let me just move my slide along. So what is the, sorry, I'm trying to move my slide along. Fantastic. Okay. Yep. Okay. So I'll give you then an overview of the trainings that we've been doing. So we have trained several hospital teams, 2 from level 6, 5 from level 5, 4 from level 7, and 1 from a faith-based hospital. And in total, we've trained over 150 healthcare providers. And it's been a mix of consultants, medical officers, nurses. We had, I think, in one training, 3 biomedical engineers and 1 nutritionist. We like to have a diverse team, if people can come as teams, so maybe 2 or 3 people from a unit. So if it's outpatient, if you can have maybe 2 people or 3 people from a unit, from the outpatient, then it works, because then they're able they're able to train together and therefore have conversations together. What are some of the things that we cover in the simulation-based team training? One is we train on a product that's a comprehensive care ventilator. The reason we do that is because this is funded by Gradient Health Systems, where they had supplied ventilators to certain hospitals. So those hospitals that we've trained are hospitals that have this CCV, the ventilator in their hospital. So we do a refresher on the product so that we can be sure that they know how to use it. But then we also incorporate some critical care skills, critical care and emergency medicine skills. And some of the skills that we then incorporate into that are airway management and then mechanical ventilation as well. Those will be the 2 that we do a lot of. And we have found that even actually training people how to manage the airway is something they have appreciated. Because a lot of the staff who are sent to those trainings are critical care, maybe medical officers, or sometimes they are coming from outpatient or maternity. And so when they come, we teach them how to bag mask, how to intubate, how to use the ventilator, basic setting of the ventilator, then they feel that they've gained some skills. We also incorporate the CRM, which is because we don't want to train people as individuals. We want them as teams. And so we emphasize those principles that we had talked about and how they come into play. There are some hospitals that we do introduction to simulation. We've had some trainings where we've had team leaders. So when we have team leaders coming for the training, then we do some simulation, introducing them to what simulation is, how they can do simulations, what they require, what types of simulations that they can utilize. And then we also then teach how to design scenarios. So we do some scenarios for them, and then we have a tool that we use that we then teach them how to use, and they build their own scenarios. And then we break them up into teams and allow for the teams to run scenarios for each other. And after they run the scenarios, then we also do debriefing. So after every scenario, we spend time debriefing, and on the final day, on the afternoon, we would then do a way forward. What are we taking home? What things are we going to incorporate in our practice or in our hospitals? So this is a picture of one of the teams, and they are, this is in their hospital, and it's in a building that's that's used mostly for meetings. So it is an it's an in-hospital training that we are doing. We're using their facility. And so here, this is the CCV, so we're training them. They're setting it so that we're sure they know how to use it. And you can see that we have brought a trolley, and we have brought a mannequin here, because after we finish this, we're then going to do simulations in the same space. So, and this is a good a picture to demonstrate that you can do simulations within your hospital with whatever you have. So they already had mannequins, and they already had stretchers, and of course we got gloves and fluids and all that we could use, needles and syringes that we used for simulation. Now, this is the same hospital in the same space, and they are running a simulation for each other. You can see the person running the simulation here. She's holding a paper where she's running the simulation, and she has her assistant on this side, and the simulation is actually on a neonate. So they had set a scenario on neonatal sepsis, and that is now what they are running. And it's always a good practice. It's always great to see them create their own scenarios from their own comfort zone for others, and then they see how their team members perform, and the debriefing is always very interesting to listen to. This is another training that was the airway training that I'm telling you about, and we have two instructors here. We tend to use anesthesiologists who do most of our training, and they are training this hospital staff. This is not within a hospital, so they were off-site, but not in a sim lab, and here they're being taught about airway management. This is also another training where, again, these are staff who were not, this is offsite in a hotel. And again, you have another team running a scenario. So this gentleman and the lady here are both critical care nurses, and they're running this scenario for this team here, where you have a medical officer, a nurse, a clinical officer, anesthesia, and then a consultant anesthesiologist. So this is a team. It's diverse, and they are being run, the scenario is being run on them by these two team members, and they're having to work through whatever the scenario is. This is a scenario that's taking place in our simulation center at Kenya Medical Training College. So this is the theater side, and here this hospital team is doing a simulation or scenario where they are transporting a patient. So they are required to come from ICU and come with a ventilator, which is over here, to receive this patient who is in theater and transport them back. So the scenario has been made in such a way that it's more of a handover, but it also is requiring that they set the vent and utilize the vent to transport a patient. And this is the same, a similar scenario. Again, another hospital group, but it's very similar. Again, they are transporting a patient, and they are now receiving the report. And then we say that at the end of it, what we require that they do a way forward. And this is a session where they are sitting and discussing. This is a team from a specific hospital. It has a critical care nurse in it. It has two critical care nurses, I think, and a clinical officer and anesthesiologist sitting here, and they're thinking, with what we have learned, what are we going to do? Some of the common areas that have come up, hospitals are unique, but I picked out the ones that, the areas that have a common thread. One is training, and as they run scenarios for one another, people are able to recognize what their strengths are. Because if you have in a hospital a critical care trained nurse, maybe a pediatric nurse, maybe you have an emergency medicine clinical officer, an anesthesiologist, a medical officer, pediatrician or obstetrician, everybody has their skill set and their knowledge base. But when they run simulations for each other, they're able to see how they contribute to the team functioning and to the knowledge base of others. And many of them have said that what they would like to do is continue to do trainings for each other. I remember one incident where a pediatric nurse set a scenario of a convulsing baby. And there was a confession from one of the team members. They said, when I saw it was a baby, I panicked because I'm not confident with babies. So already then they understood that. Now when they have children coming to them or babies, they can easily consult the pediatric nurse because she is well versed and they can share knowledge and she can be able to train them. So training is one of the things that has come up. The other thing that has come up in our way forwards is departmental CMEs. I think we take those for granted, that if you're in an institution where it happens, but a lot of hospitals they don't have CMEs. And so as many of them have resolved that they would be doing CMEs at a departmental level regularly. There's some hospitals also who've identified that they're not able to deal with emergencies, and they want to have dedicated areas where when an emergency comes, they're able to manage that emergency adequately, at least stabilize and refer. Remember, we said with the trainings that we've done are mostly level 4, and so they're the ones who have those kinds of unique challenges. As many hospitals have recognized the need for protocols, that they don't really have protocols in their institutions, and they said they need to develop protocols in simple things, even things to do with referral, things to do with the management of cardiac arrest. And with that, many of them have agreed that they need to put them up somewhere where people can be able to use them. A lot of hospitals, conversations with management also came out after the SPTT. One, because they feel that they want to have simulations and training regularly. So, so they need to get buy-in from management. A lot of them, it's actually resources, where they recognize and identify that for them to manage crises, they do need resources. And they have even identified a spokesperson from their group to go and speak with the management. And that has worked well, because usually we work with the hospital management to invite to send their staff, and so they have chosen this team. So we tell them this is an opportunity for you to give feedback on your training, and then also articulate the things that you have noticed and that you would want to start to implement or to change. Some hospitals have picked up that they want to do monthly simulations, and I continuously follow up, and I have seen that some of them have picked that up and are doing it. And transport, we said that we were training them on using this specific vent, and many of the hospitals had the vent and they were not using them. And we were able to show them that you could use them for transport. And many times critically ill patients who are intubated are transported being bagged. And we're telling them that this particular vent can be used for transport. So it also became one of the resolutions that they could use it for transport. So finally, what I want to say is that training of hospital teams is very important. And I think the time has come for us to not train individual persons. We need to do that, yes, but we also need to concentrate on training our teams so that our hospital teams have a shared mental model. They function efficiently, and they are able to work together in a way that produces better outcomes. So thank you.
Thank you very much for that thought-provoking presentation. I always see us working as teams, and I never even thought of how we never really train together. So working together can be a bit tricky. So there are a few questions. One person said it's a very innovative concept, trained separately but have to work together. Team development is essential. Please comment on management of inter-cadre conflict.
You know, that is a very good point. And I have found, in fact, just yesterday, somebody was commenting that, you know, the difference between debriefing after simulation is that you're not laying blame. So, and I think one of the ways to begin to manage inter-cadre conflict is doing trainings together. So, and of course, I'm pushing simulation, but I think if we do trainings together, and we are able to incorporate some of the CRM principles, they overlap many of the ideas and issues that we have. Because when with CRM, we emphasize the fact that there must be a leader, and we always say the leader doesn't have to be a specific cadre. It can be anybody. And actually, when you run simulations, people quickly see their own weaknesses and now concede to the fact that somebody else can actually lead. So if you have maybe a critical care trained nurse who's very, who knows, you know, training BLS or ACLS, they can easily run a resuscitation. They might be better placed to run that resuscitation as a leader than maybe a medical officer who's fresh off, school, and maybe does not have the skill set. So I think those doing simulation allows for that because it's a safe environment, and then people are also allowed to air their views. So some of the questions we ask are, what did you feel about that? And what about your role? How confident were you? So people can actually bring their feelings and emotions to the table, and then you can address it. So I think that would be my take on how to resolve conflicts amongst cadres. It's putting them in a situation where they appreciate each other's role and expertise.
Nice, thank you. Thank you very much, Dr. Most of the comments I can see is really people mentioning how wonderful your presentation is. For me, I'd like to make a comment. I noticed from your pictures that it's not a specific lab that the simulation exercises are going on, and I'd love to talk more about that, because there's this notion that it has to be in a specific place, it has to be like this and that for it to actually be a simulation. What's the most simplest way and the most practical, rather, way for departments to actually have the monthly simulations that you talked about? Over to you.
Yeah, thank you. And that will go to quite a number of questions people asking about that. So our simulation lab is mostly, it was tailored for critical care as well as anesthesia. So it has a theater on one side and an ICU on one side. So it has the equipment and the drugs for that. But we have also been able to use it for other things. So because the critical care is a bed with a cot, you can easily make it a maternity triage room. So with the use of the assimilated patient, so you just have one of the staff, putting something that makes them look pregnant, and they have PT or they convulse, and so it can. We have found that it's easily adaptable to any kind of scenario. It can also be an outpatient emergency department. So I think your simulation space is anything that you want it to be. All you always say is that to do a simulation, you need to have planned in advance. So you have to think through what you need, because we said simulation, it must look real life. it must represent a real life scenario. So you need to bring in the props and the things that, to make it look like it's that place you're saying, because you also don't want to keep telling people, imagine it is, imagine that this is, so we don't want them to imagine too many things. So we want to bring everything that is needed into that space. And therefore, in situ hospital simulations that would work perfectly. I mean, in the outpatient, where you are, if there's an empty cubicle, you can do a simulation for an hour. Instead of a CME where you're sitting doing the didactics, you can just simply do a simulation. And it can be based on a scenario or a case that happened that maybe one identifies that the team didn't function well, and therefore you use that. I always tell teams that look for things that happen very commonly, use those for simulation, and then also look for the ones that happen rarely but cause crises, that then you use those for simulation as well. So there's no list of things. It just depends on what you want to use a simulations space for, and you can keep bringing and adding and building to your simulation.
Thank you very much. Another interesting question is, how do a lower cadre correct somebody? Because there's that fear, or probably you feel like you're not doing the right thing. How do you correct somebody who's superior to you, such that it doesn't seem like it's insubordination? Over to you.
Yeah, that's tricky. But and one of the things with the CRM is that you're taught about leadership and followership. So we say the leader is a person who is, directing, but it doesn't mean that the followers are clueless. they also are contributing to the outcome, and therefore it's how do we communicate with one another and making suggestions. So can we consider doing this? I think we are not achieving this, because not being assertive when you're functioning as a team has its disadvantage. It can cause you to have poor outcomes. It does not make sense for when a crisis is over for someone to sit and say, but I knew it was going to be that way because we did not do this. So we're saying no, we should say whatever is the right thing to do, so that it happens, so that there is correction. Or sometimes a person has forgotten, or is not aware that there's things that they are overlooking. With CRM, you're also saying that it's not about who is right, but it's about what is right. And I think that's why it's important, if you feel your teams don't function properly because of those dynamics, that you do more of simulations, because it's a safe environment where we are not assessing each other, we're not laying blame, we're just running the scenario, and then we are debriefing. And whatever happens in the simulation ends in the simulation. It's not going to go on to departmental meeting minutes. So I think I would say, if simulation could be a way to provide a safe environment to tackle those team dynamic issues that are bringing the compromising team function.
Agreed, Daktari. I believe it's important to do the simulation. That's when you break the barriers. That's when you get used to each other and be comfortable, especially when you're doing the debriefing and you realize, oh, you're supposed to have told me that during the exercise, not after. So I guess it's important in the debriefing exercises. Prof. Wanyoro, do you have any question?
Not really, but maybe some people can also look at the Pronto simulation model. They have done quite a lot, especially in the obstetrics space, as well as the intrapartum phase in trying to save neonates, especially in preterm babies. So it's another good model to look at. And basically the principles are the same. They use a lot of ESBA as in the principles, and also a lot of in mentorship programs. So that's another space that people can look at. Thank you.
Thank you.
Thank you very much, Professor. There's somebody who's asking regarding if you offer such trainings, simulations, and where do you do them? How do you support? I noticed in the presentation you mentioned there were 8 counties. Yeah.
Yeah. So one, we welcome people to come to the KMTC simulation lab, and we can start conversation from there. And one can also send an email, and I can put my email on the chat, and so we can start to talk about that. If we have if we know of people close to wherever you are who could help with doing simulations, or if you're thinking about setting it up, there's a lot of conversations that we could have to see how we can help.
Sorry, so Dr. from your experience, the places which you've gone to do the simulation exercises, what outcome have you experienced? What feedback did you get from the trainees?
That's a good question. So we always, do evaluate ourselves when we do evaluation based on their confidence level in several things. One, if we're teaching how to do scenario building, we want to know how confident are you in that, and then also in debriefing. And then we also ask them to evaluate us on the course content and relevance, and how much collaborative activities that we've had, and also give us any other feedback that they want to give. We do our training for 2 days. On the length of the training, most people feel it's appropriate. You'd have just a few people who say they would like to do this for an extra day. So 2 days has worked for us as the optimal number of days. In terms of the course content, what I have shared with you that we give, we've always had majority of the people say that participants feel that the content is adequate and relevant to them. Actually, we've gotten such positive feedback on the course, and a very good way forwards was people sit back and think through their time that they've spent. Everybody has evaluated us and felt that it was very useful for their time, and that they've picked up important points for them to utilize. Now, the problem that we have faced is that once they go back, because of the conflicting responsibilities, that they take a very long time before they start to do simulations or start to implement what they had said that they would want to do. So we have very good people saying, this is great, this is something we need to do, we need to have this, but then a month, 2 months, 3 months down the road, you find we're saying, yeah, I still want to do it, but I haven't gotten around to doing it. So we still need to overcome that.
Yes, sorry, there was a question I missed. Somebody was asking, what does the simulation exercise entail? Does it include emergency drugs, or it's just nursing care only? I think they want to get a good concept on what simulation.
Yeah, that's a good question. Well, simulation is anything you want it to be. It's and hence that's why we say we spend some time talking about what simulation is and how to build scenarios, because your first question when you build scenarios is what is your goal, and then who are you targeting. So depending on who you're targeting, you would make your simulation. So our bias has been teams, so we don't focus only on nursing or specific cadre skills. We look at it, we create scenarios that allow for every person to participate. So I will give the example of when we went and we had biomed joining the simulation. So the biomed actually ran their simulation, and what they did is that they tampered with the equipment and then had the participants run through a scenario where they are assembling the equipment, and so that they could see whether they can be able to troubleshoot and see when they are missing something or something's not functioning correctly. We've also had biomed, especially when we encourage them to call others in your simulations, so that if you're having challenges with your equipment, then you should call a biomed to come and assist you. And so a team member can be a biomed person to come in and assist. So it's all cadres contributing to the simulation experience to get a good outcome. It's not tailored to only a specific thing or a specific group.
Thank you. It's interesting you mentioned biomed, because one of the audience is asking if you've incorporated psychologists in the team, especially during the briefing.
And that's a very good question, because we do have one of the questions that we ask in terms of evaluating what people experience a lot more, because when they're coming for the course, we give them a pre-course evaluation, trying to understand who they are, their work experience, but also what they see most often in their practice. And one of the questions is breaking bad news, it is one of the areas that definitely needs a lot more simulations around. Even things like ethical issues. So if a patient dies, when you're resuscitating, having the simulation of how do you break bad news to a parent. The only aspects that we have covered is perhaps a parent in a room when incorporated in our scenarios is a parent in a room or a relative in a room when a crisis is happening on a patient, and then how do you manage the person. So they get hysterical, or they ask what's happening, and they need to be moved out of the room and talked to and communicated. So we haven't gone to the next level, and I would say that it would be fantastic if even psychologists could run some simulations along those lines for hospital staff. That's for sure. I also need to mention that we've never had actually a counselor sent by any hospital. They tend to send medical officers, nurses. So there is definitely a weakness there.
Thank you for that very elaborative answer. I think the last question is regarding to leadership. Question is regarding to what type of leadership do we need on the interprofessional teams?
And actually, it's a question that you can only ask teams, because when you do simulation with teams, you then understand their thinking. Many times, sometimes I have seen teams when we do simulation, the older person thinks automatically they should be the leader, and so they take charge. Or sometimes you'll find that it is the doctor who feels that they should be the leader, and so they take charge. But when you sit in the debriefing with the team and ask who was the leader, then they are able to actually evaluate why they picked the leader they picked. And then you ask them, what was the things that they so worked well with their team, and many of the times they identify either followership as a problem or leadership as a problem. They have found many times people don't even verbalize who is the leader. They just assume that because so and so is here, they are the leader. And then also saying that perhaps we need to verbalize who the leader is, and then also ask that recognize that anybody can be the leader, because the leader is not doing a specific task. They're not, but they are looking globally at how the scenario is running and directing each of the team members, and that leadership can rotate from one person to another, especially if people feel that they are, sort of getting stuck, and that also followers can contribute to the thinking of the leader. So the leader doesn't have to be the person who knows everything, but needs to be the person who is willing to oversee the process, and it can be anybody.
Thank you. Thank you very much, Dr. for this session. I don't know if you have any parting messages before I wind up.
I just want to say thank you for the opportunity. Thank you, Kenyatta Research Office, for this chance. And we're looking forward to more conversations and collaborations between KMTC and Kenyatta.
Thank you very much, Dr. for your wonderful work. I'm sure it's impacting a lot of people. Just a brief announcement. We have started to give the nurses CPD point, the nursing cadre. However, you can only redeem it in 48 hours. So it will be given out and you need to redeem it in 48 hours. For the pharmacy, kindly check the website. There's a way how you can actually redeem your CPD points. I'm sure we're having a lot of challenges in that there, but kindly just reference the video so that you can be able to redeem your points. Thank you very much, Dr. again, for your very informative and thought-provocative presentation. Thank you, the research team as well, for organizing. Have a good day. I can see we are having the next session. Okay. So have a good day, people. Goodbye.
Goodbye. Thank you.